Good morning, everyone. We're going to get ready for the 9 o'clock session. We're starting just a few minutes late. This is the session related to public safety. So if you're planning to join us for the 9 o'clock, please find a seat. Okay, great. So thank you everyone for being here today. This is the session, Emerging Public Safety Strategies to Provide Alternative Emergency Response. And I am Aubrey Gonzalez. I am LGHN Vice President for Professional Development, and I also serve at the City of Phoenix as Assistant Housing Director. For the past 3 years, recently I was in the police department, and so as we were developing concepts for the sessions in this conference, there are 2 public safety sessions that I will be moderating, this one today and one tomorrow, and also lending some of my experience working in the police department along with our panelists. And so I want to introduce you today to our 2 panelists related to this subject. So the first one we have is Director Scott Snow here to my right. And Director Snow has worked for the Denver Police Department in the area of behavioral health needs and victim services, including events. Scott has been speaker at local, state, national, and international conferences related to topics involving victim services, behavioral health response, procedural justice, and other areas involving creative law enforcement response. He is involved as chair of Denver Sexual Assault Interagency Council, a member of Denver's Victim Service and Advocacy Network Steering Committee, and a member of the International Association of Chiefs of Police Victim Services Committee. So welcome, Scott. And our second panelist on the end here is Chris Richardson. Chris is the Associate Director of Criminal Justice Services at the Mental Health Center of Denver, most notably overseeing Denver's Co-Response Unit, a program that pairs licensed mental health clinicians with Denver police officers, providing on-scene support, crisis de-escalation, service connection, and follow-up visits to individuals experiencing mental health crisis in the Denver area. More recently, overseeing the daily operations to Denver's Star Pilot, which you'll be hearing about today, that provides a civilian-based response to low-level 911 calls. So now I'll turn it over to Scott and Chris, who will walk you through their presentation on their programs, their efforts. You know, as we know, the events of 2020 and 2021 really put focus and attention on responses from our public safety partners and other partners in our society in responding to crisis calls. And so we're going to hear about a great program here happening in our own backyard here in Colorado in the Denver area. And so with that, I'll turn it over to our panelists.
Thank you for having us here, both in person and virtually. This is kind of a different experience to realize there are people that I can't see that are participating in this, but it is an honor for us to be here, to walk through over the next hour or so just a little bit of what we've been able to look at and do in the city and county of Denver, tied into behavioral health response and creating an alternative response to individuals in behavioral health crisis and communities that are affected by behavioral health issues and needs. We recognize that ultimately and operationally, what we're going to talk about kind of lies with and in a public safety realm. But outcomes that we are supporting impact families, impact communities. There's a role for anyone in a community to support and to promote and to lead your communities into rethinking response to people experiencing behavioral health issues. So we appreciate the opportunity. Chris and I have, particularly as everyone here has experienced over the last 18 months, wasn't uncommon to have 2 or 3 regular work meetings a day. And when the world shut down and went virtual, we're having 6 and 7 meetings a day. Probably 5 of those meetings a day for the last year have been Chris and I allowed the opportunity, given the opportunity to speak with cities across the country about alternative behavioral health response. And Denver clearly is standing on the shoulders of other cities and other leaders that are doing this. We didn't invent any of this, but I think Denver has been very thoughtful and very progressive, particularly from a law enforcement and public safety mindset, to advance and progress behavioral health responses. So we're going to dive into two of the areas that we've been working in over the last 5 years that are our co-responders that pair licensed behavioral health clinicians with police officers, and our newest endeavor is STAR, Support Team Assisted Response, that pairs a paramedic or a EMT with a licensed behavioral health specialist. So I'm going to start out, kind of give a little bit of historical perspective, and then Chris will go through, as Chris oversees the daily operations of both our co-responders. As you'll see, we started with 3 clinicians 5.5 years ago. We have 40 clinical staff today. I've never seen anything in 27 years in the Denver Police Department. I've never seen anything as quickly and well integrated as the response to behavioral health alternatives have been. And some of that proof is in the fact that we went from 3 to 40 in a 5-year period. So go back a little bit to the origins of public safety, police response, and crisis intervention. In 1987, there was I think he was a 27-year-old man in Memphis, Tennessee, that had stabbed and cut himself 120 times. The response that came from the Memphis Police Department, not unlike what we're going to talk about in Denver a few years later, was to shoot and kill him. 2003, a 15-year-old African-American young man in the Park Hill neighborhood of Denver named Paul Childs. His sister called 911 because Paul had a knife and was acting erratic. There had been close to 900 911 calls come from the Childs residence in the prior 2 years. It was very clear and known to the officers in and around that area that there were behavioral health needs that this family was struggling with. Paul Childs was shot and killed by a Denver police officer holding a knife in his doorway. Sadly, we all too often see and recognize change comes through struggle. That's the lightning bolt. Regulation, legislation, reform often are the result of tragedy. And public safety response to behavioral health needs is no different. But what I think we have seized on, and I mean this broadly from a law enforcement, public safety perspective across the United States, and I can speak specifically for the city and county of Denver, is instead of waiting for tragedy to drive the next change, is to be progressive, is to look forward. And a big part of that is leaning into our communities, not through protest and not through unrest and that type of engagement, but proactive partnership to ask for and expect communities to be candid and leaders within communities to tell us their experiences and their interest in then us being responsive and progressive in true partnership. Just a snapshot of Denver. In 2001, prior to the incident that I just described, DPD, with the support of the city and partially engaged community, started doing crisis intervention training, a formal 40-hour training for, at the time it was the goal to have at least an officer on every shift around the clock to have CIT training. We've since changed the goal to have 100% of our department trained in 40-hour CIT training, and then clearly what we're going to talk about here is the kind of the evolved outside the box kind of thinking around behavioral health response. So that went to an assessment response team that was uniformed officers that had significant more training around crisis intervention, but it maintained the response to behavioral health needs strictly and specifically with a uniformed response. There was a civilian psychologist that helped coordinate it, but for the most part, it was uniformed police that were going out. They were still trained, and their backgrounds were in law enforcement and policing with enhanced training in crisis intervention. But as we looked back and continued to evolve, we recognized that was good, but not where we needed to be. So in 2014, we started exploring and looking at some models around the country. We looked at San Antonio. We looked at Los Angeles, Houston, and Harris County, Johnsonville, Kansas had police co-response with some level of behavioral health professional responding with a police officer. So 2015 into 2016 is when we contracted with the Mental Health Center of Denver, Chris being one of the first 3 original clinicians that came in, and then started building out what's now our Crisis Intervention Response Unit. From there, we looked at, and Chris will go into some detail about this, a model in Eugene, Oregon called Cahoots that started about 30 years ago. Literally, it started in the parking lot of a Grateful Dead concert with people wanting to reimagine how people were engaged by law enforcement that we're dealing with. I can only imagine 30 years ago in Eugene, Oregon, it was probably substance use based if it was occurring in a Grateful Dead concert parking lot. But it was a behavioral health conversation that later we then took on, and recognizing significant differences between community and population within Eugene, Oregon, and Denver, Colorado, we're standing on their shoulders to roll out something that has also been looked at by a number of cities, because we are a larger city with a more diverse population and some more socioeconomic and other interests and needs that have allowed our brand new year-plus-old STAR to also be looked at and replicated. Real quick on this, and I think this will probably be a theme that you will continue to come back to through multiple workshops and discussions over the conference today and tomorrow, is that this is about strategic partnership with an emphasis on the strategy, on the thoughtfulness going into considerations for what might be necessary or needed or supported in your community, and also what won't be supported potentially or might be objected to. But that's where we all have a responsibility as leaders, and building leadership is sometimes to take on those things that may be unpopular or misunderstood and advance the understanding, because it advances the outcomes and betters our communities. Sorry, and I'm looking down here because, sorry, I'm not avoiding eye contact. That's where our screen is. So, yeah, pretty much covered that. In addition to the behavioral health that we have established in the Crisis Intervention Response Unit, the department has also hired, I think we're now up to 7 outreach case coordinators that are Denver Police Department employees that also work directly out of the chief's office, demonstrating some of the training I do around other aspects of law enforcement. I reinforce that if you want to see a department's priorities, look at their organizational structure. Look at the org chart, look at their budget, and look at their org chart. And communities and individuals can get a pretty good idea of where a police department's priorities are by just taking a look at the organizational chart. So with that, the chief, Paul Pazin in Denver, established our outreach case coordinators work directly under supervision from a lieutenant in the chief's office to demonstrate that our ongoing response to behavioral health outcomes is going to be a top priority of the Denver Police Department. I'll touch on this because I think this is a question that comes up frequently as we're talking to communities around alternative behavioral health response. There are 3 primary operational models that are utilized currently. Denver has touched all of these, and we have now. I'll start with the model that we currently support is a true paired co-response. So our clinicians ride with police officers. They're in the same car, dispatched to the same 911 calls at the same time. They're working in tandem as they're approaching the call to look at background information, history from both a public safety perspective as well as a behavioral health perspective, and databases, so they can be as informed as possible once they arrive and make contact with the individuals at the scene. And we rotate. It's a rotational. Instead of assigning a clinician to a specific or singular officer or car, they rotate with all the officers through every precinct on every shift, so that we are intentional about trying to not only expand and enhance kind of across the department understanding of behavioral health response, and almost by osmosis. Our clinicians learn more about public safety just by being with cops 10, 12 hours a day. And our police officers learn more about behavioral health by being exposed to clinicians 10 to 12 hours a day. So we support that our current model is the best for Denver, but there's also a dedicated team that we started with in Denver where we had our initial 3 clinical staff were assigned to one specific police officer, and she and our clinicians were the only ones that were basically responding to behavioral health calls. And what we did, and as everyone had to make adjustments and pivot through challenges through pandemic lockdown, promoting social distancing, promoting those things that were recommended to try to keep our department and our communities safe from coronavirus, we did use the secondary response model where clinicians operated in solo vehicles, police officers operated in solo vehicles, and they would respond together. The clinicians would be called out by the initial responding officer. There are a number of agencies that look at that. We just believe that there's more value and better outcomes promoted if a clinical staff member and a police officer are in a shared car, having a shared experience from the time the call comes out to the resolution of the call. I'm going to touch on funding very briefly. We could probably spend a whole 2-day workshop, well, at least 1 day, talking about funding, because this is clearly an area of interest for municipalities. As everybody's budgets are tight, and there's competing priorities across every city in the country. Denver, and I'll focus on this a little bit more because this is replicable to any community, and also demonstrates an opportunity for community to lean in and support and participate in improved behavioral health outcomes. In 2018, the city of Denver put to the voters a ballot initiative that basically created 25 cents for every $100 an increase in sales tax. It went to what's now the Caring for Denver Foundation. So you think about it's only 25 cents on every $100 spent. That generates approximately $36 million for Denver. And the initiative, passed overwhelmingly by the voters in the city and county of Denver, is exclusively for funding for behavioral health needs. And part of the ordinance that was created gives the city and county of Denver 10% of the collected revenue each year. So while the revenue collection may change or may vary year to year, we know that we have sustained long-term funding thanks to the forward-thinking members of our communities in Denver that said, we'll pay 25 cents on every $100 because we know we have behavioral health needs. And law enforcement clearly, public safety clearly cannot handle behavioral health needs without support from the community. Those of you who are from areas or states that are part of Medicaid expansion, you've got additional opportunities for funding. And Chris, please feel free if you want to jump in on any of this because I'm going to segue over to you here in just a second. But definitely follow up because there are opportunities to explore funding and monies that are out there in greater depth. I want to turn over the majority of the remainder of the presentation to Chris, who's really going to dive into some of the outcomes and some of the operational aspects of our co-responders and our STAR program.
Well, thanks for having me. I think from our standpoint, I always like to start in 2016 when we had our co-responders, and it was the 3 of us that showed up to one police district and kind of had that first, what am I doing in a police district? Why are they staring at me weird? And why do I feel like the last person picked on a volleyball team? It was a very unique opportunity to actually explore what it's like to actually respond to behavioral health crisis in the 911 system. Our partners being the police department and all of us not knowing what this is going to look like. So it was about 50 first dates of showing up every single day and saying, I'm here to ride with you and I want to help support whoever you have contact with in that context. And the officer being like, wait, what are you doing now? You're riding with us? And I think it took a little bit of time building a relationship, building what our skill sets are that can complement what a 911 response looks like, and the different philosophy of how we approach situations. We have the skills based in de-escalation, but we also have the skills in coming at people as we're here to help, we're here to support you, we recognize that you might be going through something right now, and 911 is the response. We don't want 911 to be the response. We want there to be a more wraparound, holistic way to get you long-term support. And how can we break down those barriers to make sure you get there? So naturally, it took a little bit of buy-in with police about what this program was going to look like. But over time, when we started being able to see outcomes of individuals that they were having consistent contact with, but all of a sudden we're no longer calling 911. Police were no longer having to have contact with that individual. And they're starting to have this person's family is actually saying they're doing really well. They actually just started an employment program. They're taking meds. They're seeing a psychiatrist, a therapist, whatever that might be for that person. Police started saying, well, that worked. We need to actually start expanding on that. And so police are a little bit like wildfire when it comes to talking amongst each other. And all of a sudden we had these other districts going, so when are clinicians coming our direction? And that's a wonderful problem to have because we don't have to sell ourselves to another district. Instead, it's cool, let us get you some bodies and we'll actually start building that relationship in that. So over the past 5 years, we've been able to expand citywide 7 days a week in every single district with our higher population districts actually being able to have more clinical space. Now, the funny thing about giving a social worker a police radio is we're going to question every single thing that comes across that. Sometimes we just literally hear something on the radio and we're like, one, why is that a 911 call? And two, why are we sending police in general? So we started batting this idea around of if we're going to send police to everything, what if we came up with a more creative solution for what that response can be? So far, it's been fire, EMS, and police. And so we kind of said, what would it look like to actually send a civilian response? And has this ever been done before? And I think that is where we kind of started our whole process when it came to STAR. What we noticed specifically is that calls for behavioral health stuff are going up on a regular basis in Denver. Every single year we seem to have an increase, and that could be many things. Either people are in a more acute crisis, that 911 is the response, or there's more recognition of behavioral health response or behaviors in communities. There's more education about mental health. There's more understanding of kind of what's going on. And I hope part of that is very true. But being able to meet that need in the most effective way by sending the right response, not just a one-size-fits-all response. Our partners at the Department of Safety, Chief Pazin, have been wonderful stewards. We had this idea of how do we have a civilian response, and we basically just went and talked to the chief and said, we have an idea. We just want to explore it. We cold called Eugene, Oregon, said we heard about this amazing program you guys have called Cahoots. Never heard of it. They were super open and willing to have us come up there for basically a site visit. And Chief Pazin at the time was like, I like this idea, like run with it, but I want to bring community partners attached with it. So we got a whole delegation of Denver communities that represented our entire community. Not only police, Mental Health Center of Denver, 911, but organizations like the Harm Reduction Action Center, which is our local needle exchange, Servicio de la Raza, which is our Spanish clinic on the west side, Dasher, the street medics. We had Denver Justice Project, which is a huge advocate of police reform and being able to actually have a alternative response. Caring for Denver, Representative Leslie Harrod was present. And being able, did I miss anyone? Okay, yeah, okay. So yeah, we brought all these entities together and said we want to be able to kind of transform this and have it be community-led and being able to do this in an effective way. So before the pandemic actually hit in 2018, we actually went up there for 3 days. We were able to meet with the leaders of Cahoots. We're able to actually do ride-alongs with them to kind of see how it was that they were interacting. And it was a lot of community support. It was relationships with 911. It was understanding of how a call gets to 911 and how they dispatch these individuals in a safe manner to make sure that they're not being put in risk. And also the partnership that they have with the law enforcement. The fun part about Cahoots is, yes, it was formed in a Grateful Dead parking lot, but the name Cahoots actually came from these very crunchy granola individuals identifying that they're going to be working with police, and it looks like they're in cahoots with them. So I love how they phrase that. So we took all that information and we said, we're going to bring this down to Denver and we're going to start having meetings about what would this look like and how do we do this and how do we get it funded and how do we pilot it and how do we make sure that we're using data but also community voices to help understand what a civilian response looks like. The original working groups, we were meeting on a pretty consistent basis about 2 weeks. Like Scott said, Caring for Denver, it was like catching lightning in a bottle. We had an idea and we had funding that had availability. So we kind of talked to the Caring for Denver folk to say, we'd like to actually pilot this in the downtown corridor area. Being able to recognize that that is the highest call volume of the buckets that we're trying to capture. But we want to be able to do it to see if it works. We want to do it for 6 months, and then if it works on that 6 months, we'd like to expand it for another 6 months, and then kind of build out what it might look like if it is successful. The buckets that we notified from Eugene, Oregon were specifically assist, intoxicated person, suicidal series, welfare checks, indecent exposure, trespass, and syringe disposal. That's the buckets that a dispatcher in Eugene would send the Cahoots van to. We didn't think that that was anything to mess with, and we wanted to start our pilot specifically tailoring to those buckets. So through our data, this is one of those fun things, being a mental health provider, I don't have access to city data the way the city does, but they were able to actually use data to inform us where the high call volumes were and what times we needed to operate this van. So we use that data to be able to inform what we were gonna do. It's 40 hours a week currently, Monday through Friday, 10 a.m. to 6 p.m., which I'm going to be honest with you, 10 a.m. to 6 p.m. was a confusing one to me because I thought it was going to be more of a night shift, night thing. But it turns out that that's more of individuals when people are coming to businesses, when people are leaving their homes and starting to recognize individuals in our community that might be experiencing behavioral health crisis. So that's when we decided that is kind of the location and time that we actually need to be at. This is the downtown corridor area where we staff the pilot, affectionately called the Lollipop Pilot. It's basically the entire downtown corridor area followed by Broadway that runs south. The thing, you guys are all with the city, so I like that I can talk to you about this. What I love about city agencies is when they say jump, we need to jump. So we were going to start this program, I think in March 2020. A little thing called Corona happened, so we naturally had to kind of revise how we were actually going to change when we were going to actually deploy this thing. But we recognized also that our community at the time was hurting. We had individuals that had support that no longer had support. We had individuals that felt like they could go, they used to go to their families, their friends, have that more social connections that were basically lost. And so we started noticing a lot more uptick in 911 calls related to anxiety, stress, fear related to being isolated. And I think as this community, we started talking about we need to actually be we need to lean in. We need to be able to help support our communities in this moment. So on, I think it was a Thursday in May, we actually said, the city said, hey, we want to deploy this on Monday. So a quick little 4-day turnaround. We didn't have a clinician at the time to actually staff the van, so me and my colleague kind of just canceled our summer and said, we're going to be the clinician that are going to take on this van and take on this initial pilot. So June 1, 2020, we were able to start this program, and we really haven't looked back since. There's a lot of discussion about responders and STAR and whether or not the two should exist at the same time, or can one just take on the other. In Denver, we are highly invested in the idea that we actually want to make sure that the spectrum of clinical response can be there at any situation. If safety issues are present, STAR would not be deployed, but a co-responder would be able to. And we want to make sure that we have that clinical lens, trauma-informed care, and best practices to help someone in that moment to be able to get that, meet their goals, whatever that might be, even if it's just safety for the day or safety for the night. So that's why we're really big on recognizing that we want both programs in existence, not only from behavioral health stuff that enhance to a more safety concern, which would be our co-responders, but also the low-level stuff where safety isn't a present, which would be a STAR dispatch, kind of a recognition of a response, sending the right response at any given time.
Just want to add, just for a second, this and not or conversation. While there wasn't a lot of volume to this in Denver, there was a recognition and understanding that over the events of the last 2 years, culminating, historic events in law enforcement, but culminating in what we saw as a nation and as a world following the death of George Floyd and the defund and reimagining police conversation, there were voices that promoted moving away from a co-response model and exclusively deploying civilians. And our position, and this gets back to my comment about sometimes leadership, I think, involves defending unpopular decisions or guiding people. We believe, to Chris's point, there are situations that will benefit from having a police officer and a clinician. The higher acuity, the public safety issues. So I would encourage you to be prepared if or as you continue these conversations in your own communities. There may be that element of we want to replace police, even co-response, with exclusive civilians in a reimagined, defund concept. We would just support that there's room for both. There's space for and need for co-response with police officers as well as the civilian response we have with STAR.
Using our data, we were able to kind of heat map where the calls were coming from in the downtown corridor area. We actually use this as a mechanism to be able to kind of say, if expansion were to happen citywide outside of the pilot area, what would that look like? Where would we be seeing the calls in our community? What areas would be high need? And being able to really inform using data how we would have more than one van. I believe during our entire one-year pilot that we had, and it is still up and running as we kind of look at expansion, we were able to respond specifically to about 1,400 calls for service that otherwise would have been responded to by police. Of those 1,400 calls, we actually didn't have to request backup or police contact on any of them. We were self-resolved that on scene, we were able to get individuals to treatment, get individuals to a different location just through transport. And then the unknown one that we kind of thought was a little weird is we actually ended calls about 10 minutes faster than a normal police response. And we think the reason is because our whole employment is knowing system navigation and being able to get people access to places based on our Rolodex of information and resources that we have in our community. So being able to immediately start talking to someone of what is it we can help you with in this moment, them identifying it and us being able to get them to it, really saves a lot of time and a lot of immediate access to places that otherwise officers don't have knowledge of and don't have system navigation experience in. We were able to, during that time frame, respond to about 2.8 of DPD's overall call load, and that's just with one van. So I think being able to see what this would look like citywide with more vans, more responses, and more availability would be pretty impactful on the 911 system, and hopefully keeping law enforcement doing things that they're more educated in, like burglary, car theft, stuff of that nature. I think I should, in the beginning picture, this is our data that we collect on a pretty regular basis. This is pretty close to our year-end report. Our highest call volumes are trespass or unwanted person. This is typically, we believe this is mainly because we're in the downtown corridor area where we do have a high homeless population, and our unhoused individuals tend to be, if they're not in a shelter, they're currently living on the street. So residents are calling, or businesses are calling to say, hey, I'm concerned about this person, what can we do? And we're making contact with those individuals. Welfare checks, assist, follow-ups are all kind of part of that top buckets that we're going to. But they all kind of have their own uniqueness attached with it, whether a welfare check is, I haven't seen this person in a while, do you mind going and just checking to see if they're okay, or it's my son isn't doing very well, can someone go and make sure that he's doing okay? And it's engaging that person consistently on what is best going to help you in this moment. We never try to force mental health treatment. We always try to talk with them through and educate them on possibilities just in general about wellness, whether that's physical health, whether that's mental health, whether that's just aspirations to do things beyond what they're currently doing, which can be as simple as education, sobriety, access to services like food stamps, Medicaid, anything, letting that person be the director of what is going to best solve this situation and making sure that we're the ones that can usher them to that situation. This is a side-by-side comparison of kind of like the differences between our co-responders and our STAR program. Our STAR program is definitely responding to the more low-level calls where safety is not a component at all. And I use safety tongue-in-cheek because there has been an education that we've had to do with 911 as well as the Department of Safety around what safety means to us. Someone yelling to us is not a safety concern. I've been yelled at a lot of times in my career as a mental health provider. That's just my job. I'm sometimes a sounding board. And I think recognizing someone in crisis that is in that moment can be agitated, they can be frustrated, they can be unhappy about a situation, and I'm there to just make sure that we can usher that in a most effective way, that the outcome can lead to them getting support on the back end, whether that's accessing day shelters, actual shelters, walk-in crisis centers, or whatever service that they feel like would be most beneficial to them. So we've definitely had to use the experience that we've brought to the table on case management and understanding of this population to kind of help assuade any concerns related to safety. Also the idea of, I think a lot of it comes up, does a person have a knife? As long as they're not wielding at me, I'm going to go to that call. I just assume everyone has a knife. I think it's a different mindset, and it's a different a frame of reference of how we help support our community, and what we kind of understand can sometimes just be the behaviors of symptoms, and it's not something that we have to be fearful of. It's something we have to be able to find a creative support for. Again, primary concerns tend to be the more mental health side. Obviously, co-occurring is something that we identify pretty regularly. I think the co-occurring is the one that's probably insanely underreported by that individual, even if there might be a co-occurring disorder, whether that's methamphetamines, opiates, alcohol, whatnot. If that person says they don't have that problem, we're collecting the data that they don't, even if we suspect it. So I think that's kind of the only, on this one, the underreported one. Some details a little bit attached with what's on the van. We recognized very early that we couldn't purchase a van on a pilot, so we had to kind of shoelace this thing together. So we actually used the Department of Safety's crash report taking van and just stripped it of all the police insignia, and then made it a little more user friendly for someone that may pop into the van for transport or access needs. We also put water and snacks in there. To be able to talk, because individuals that being able to handle water is just a kind act that can at least engage a conversation in a pretty real-time and easy way. But it's amazing because you start listening to the community that you're actually encountering. The amount of people that we actually had where we were like, hey, we're going to get you here, is that okay? And they get on the van and they're just like, man, I really wish you had sunscreen right now because it's hot outside. And we're just like, what a simple thing to have on this van. Yeah, you're right. We're going to have sunscreen on this next time. Thanks for that. And then being able to actually inform a little bit more on that is like we have individuals that are dealing with opiates right now, and being able to have a place that they can get clean supplies, but also a place that they can dispose of needles in a safe way that is not going to be threatening to legal or anything like that. So very harm reduction. But now we actually include blankets, space blankets, clothing, because a lot of people end up not having a shirt in the moment or not having pants or socks. And we've even gone so far as to have condoms, tampons, sanitary napkins, all that stuff where we were just like, didn't even think about it before, but our community actually said, I wish you had this on here. And we're like, you're really smart. Yeah, that's a great idea. And I'm sorry for us not having it on there. So really making sure that the community is informing what we're doing and continually expand on what that looks like.
Just really quickly, another opportunity that came through the community voice to us, what Chris just mentioned about supplies and things that are necessary, meeting people where they are from the van. We partnered with a local news station who did a story on STAR as part of a fundraising effort. They fundraised through the story for 24 hours and raised $20,000 to the supplies that Chris mentioned. So that was, I think they'd said historically through the same news channel that they would expect maybe $10,000. But we raised $20,000 in 24 hours from the community, just saying, you need it, you got it.
Yep. It was actually 40. Yeah. Yeah. It was one of those surprising moments of like, oh, we have a good problem to have here, being able to spend stuff on the van to be able to help support our community. So this is kind of an example of what our expansion is looking like just from a heat map standpoint. This is like where our concentrated calls are in the entire city. So these are areas specifically that we would make sure that we are responding to, but that does not include that there's areas on here that just aren't as colorful, but that still requires a need. And so being able to educate communities on what STAR access looks like, how to get access to it, how to request it, and being able to, as we move forward, kind of have a media campaign that's really intended to make sure everyone across the community has access, especially communities that are hesitant to call 911. Sometimes there is a need to call 911, but communities have such a negative experience with what that looks like, whether that's concern related to police, whether it's individuals that are in our country that are not citizens, but aren't going to call 911 because they don't want police to, interact with them in a negative way that may include deportation or something like that. So being really intentional that we are not law enforcement. We're here for a solution. We're going to support you regardless. We're going to come non-judgmentally, and we're going to we don't have to include police on any of this unless it reaches that level. And even then, with the relationships we have with police, to be able to be the mediator if it ever happens, to make sure that there's still a positive outcome for everyone at the end of the day. And I think that's when we started this program last year, the one thing we didn't account for is that we already had a clinical relationship over the past 5 years with co-response. So when we started, about 30% of our calls are actually police that go to a call, clear the scene, and say, I'm the wrong person here, let me call STAR so they can come here, tap me out, and this person get the right help to whatever it is they might need. So I think that's been a really huge showing of support from the police department of how we can actually take some of the pressure of going to all these calls off them, but also support the community in a very realistic way. This is, again, us responding to calls a little bit faster than police. Not that I'm bragging on it, but it's a very positive outcome, and we've had really positive interactions with the community related to this. And then this is our expansion plan. We actually had the mayor and city council actually approved a $1.4 million expansion back in November. And we were able to utilize a plan to have 1 to 6 teams out, 4 vans, at least 7 days a week, 16 hours a day. The goal being that we want 3 vans during this first expansion every single day to be able to respond to every corner of the city, and then be able to inform out how many more vans are we going to need to make sure we're hitting all the criteria attached with everyone that wants a STAR response gets a STAR response, that no one's waiting for something that doesn't show up. I'm hoping that there are a ton of questions because I'm a big fan of interaction and answering anything, because there's a lot to these programs, especially like community ownership, communication, buy-in, how we message out, and then also from our standpoint, how do you get entities that are so all over the place, from police, 911, communities that are more of the reimagining policing into one room and having a conversation that's meaningful and proactive to make a program that can actually be impactful to communities.
So if folks have questions, if you're in person here, please come up to one of the 2 microphones at the front. And for those of you participating virtually, you can use the chat box in Zoom. Samuel from the Glendale Hispanic Network is monitoring the chat box and has a mic, and will read some of the questions off to our panelists. Come on up.
Good morning. Good morning. Okay, there you go. So thank you very much. This is great, by the way. In my particular community, I'm from Concord, New Hampshire, and we are the state capital. The state is largely rural, but because we're one of the larger cities, we provide a lot of services in the community, including the fact that we have the state mental hospital in our community, and that tends to be sort of a revolving door, people coming in and out of services. So our police department responds quite a bit to a lot of behavioral health calls. So one of the challenges that we have when we respond is, okay, we may assess people. We actually do have a partnership with a local mental health provider that does sort of crisis intervention, not the STAR model, but more like the CIRU model that you outlined. And the challenge gets to, if you have somebody in acute distress, then what do you do with that person? Because we really have no place. A lot of times we have no beds, no place to take them. So the default ends up being that they get transported to the local emergency room. And literally, I'm not exaggerating, they're kept in the hallway because we don't have a place to put them for days on end until finally a bed opens up somewhere in some facility where they can be treated. So are you having similar challenges? If you're not, I'd love to know what you've done and how you funded it.
I think what we're seeing specifically on our co-responder side is about 16% of individuals that when we're meeting with, we just cannot get an effective safety plan in place where we do actually have to initiate a mental health hold, which means that someone has to go to a hospital for evaluation and kind of monitoring. The thing that we're noticing is that we actually have a really good relationship with our local hospital. Denver Health is our largest hospital in Denver. And being able to specifically work with their psych ER of here's what we're kind of noticing, here's what we talk with this person about, we've engaged them about whatever it might be. After this happens, like what services can we help you get to that maybe prevents this in the future or gets you more support or just someone to talk to. And being able to have that communication with the hospital allows us to have the hospital triage them much more efficiently. Being able to actually place them maybe for a quick time, or even discharging and then coordinating with us so that we can have our case managers do a follow-up the next day to say, hey, this person just got out of the hospital and we need you to follow up with them the next day to get them into services. And I think that's the one part of our team that we probably don't highlight quite enough, is that we are really good at responding to crisis. We're really good at talking about behavioral health options, solutions, and building relationships with people. But we had to hire case managers that said, that followed up with these individuals, that it was the next day service, that we weren't just saying, hey, we're here for the crisis, here's a plan, good luck, here's a referral card, I hope you make it. It was instead, I'm gonna have my person specifically come to your place, or I'm gonna have them come to this corner, or we're gonna go to the hospital and actually get you into the services. That way there's no gap in where your care is at from here to there. And making sure that that person feels supported during that. Because I think a lot of the people we have contact with kind of feel burnt a little bit by the system, and that there isn't kind of that like overpromise but underdeliver. And we want to make sure that everybody that's kind of being vulnerable and taking that step of I want to actually access something that I've never accessed before, that we're making sure that we're delivering on that. But to your point, it really is relationships with hospitals. It's really being able to work with them to say, we just don't want them sitting here. We don't want them turned and burned really quick. We really want a more comprehensive solution. And then Denver has the ability now of, we have our walk-in crisis center, which is a 24/7 crisis option for people that don't really, they just feel unsafe or unwell in the moment, but don't need to go to a hospital. So we're able to transport to that location. And then in May this year, we actually had a facility called the Solution Center, which is a much larger scale walk-in crisis center, but it's only law enforcement driven. It's police officers can recognize someone needs support in the moment, and they can bring them to the Solution Center voluntarily. It's all voluntarily, and they have therapists, they have nurses, they have a doctor, and it allows that person a 24-hour place to be where they're just around people that can keep talking to them about better options. And then if it's still like, I just don't feel good going back into the community, they can go to our CSU, which is a 7-day stay where they can constantly have contact with people. They do groups. And then if it's like this person is really like, it would benefit them to stay a little bit longer. And again, this is all voluntary. They can go up to the 3rd floor, which is a residential 30-day placement. And that has been a whirlwind resource to be able to bring people to. And not only is it police and co-responders, but STAR can drop off as well. So being able to talk with people about the options that aren't just hospitalization can kind of be a big thing.
Thank you.
Yeah.
And we'd be glad if you want into the future to follow up offline around the crisis center. It sounds like that idea of the solution center would support what your issues are.
Absolutely. Thank you.
Good morning. Thank you for the program. Bob Harrison, Washington. I'm from Washington State. As a matter of fact, Chief Murray is my police chief, so you guys know him quite well. So a few questions real quick. So I didn't see the budget for your initial pilot program. I didn't know what that maybe was. 2, what educational level are your responders at? Are they at masters, like a DCR? Are they, you just said clinicians, so I wasn't sure what that was. And then the third item was, I didn't see drug addiction up there. I think that's the biggest problem, is the drug addiction component. They may not even be homeless, but we've got groups that just like to hang out because they're in a social network with other individuals, but they're really there. They may be in temporary supportive housing, but they're drug addled and addicted, and that's their community. And how do you kind of break that cycle in terms of what you've experienced?
I think the pilot started out with $200,000 for the 1 year, and that included both the paramedic and the clinician that are on the van. Because we're with the Mental Health Center of Denver, and we have how we do our business related to Medicaid expansion, we're able to actually kind of offset the clinician costs through Medicaid. Our folk that are on the van are LCSW or LPC. which is different than Eugene. They have more of an education component related to getting people on the van. We chose the LPC LCSW route purely because on the off chance that we actually had to initiate a mental health hold, and on the van I think it was only about 5% of the calls. I think it was about 40 out of the 1,400 calls. We didn't feel like we were doing police justice by saying, hey, this person, you know, we're just not at a place where we feel that we can leave them in the community safely. So we're going to call police to do the worst part of that job by putting a hold on this person. It just seemed like it flew in the face of kind of what we were trying to do, of like having a more holistic trauma-informed practice. So the ability for us to initiate a mental health hold it allows us to actually just request an ambulance and help that person through that process. And being partnered with Denver Health, they run our ambulances, so we are actually able to talk with that person about why we're getting them to the hospital. And historically, that's it, and they go off. But we're actually now, with that relationship, able to actually get on the ambulance for transport. That way that person doesn't feel like there's this gap in, like, I don't know this new person. Instead, it's the same person. And then we go to the hospital and we're actually doing a warm handoff to the psych ER, introducing them to the doctor that we know. They're introducing them to the charge nurse. And then we're doing the wraparound saying, hey, if this person gets out, give us a call back and we'll come pick that person back up and get them back home. That way, and we've noticed that we have had no problems. Individuals feel a little bit more supported. They don't feel like there's this unknown of when you leave me, I don't know where I'm going. And we've had some pretty positive success on that. Now there is that educational component definitely puts some restraints on who can apply for the job, and I think we're going to be looking at what that looks like in the future of maybe there's a marriage of different education levels, professional options that can really kind of mirror what our community needs in that moment. What was the third question?
Budget.
Yes, yeah. So that's where community partnerships specifically are hugely important to this, because we can talk with people, but the ability to get someone access to those low barrier stuff really relies on the community taking ownership and a part of what this looks like. We work with the Harm Reduction Action Center, so we're definitely big on how do we make sure people are getting supplies when they're pre-contemplative in their thought process. When they're not ready to make a change, how do we make sure that we still let them know we support them when they are ready to make it, and that they are using safely in the process. We also have relationships with other programs throughout the entire city that are, when someone says, hey, I'm ready to get on Suboxone or methadone, that we can say, cool, we're going to get you to that place right now, or we need sober living options. What can you do with me? We have peers that are absolutely phenomenal we can connect them with that can get them to those locations. But in the moment, it really is talking with people about, here's options, and when you're ready, I'm ready here. I'm going to be here to support you. And I think a lot of people, when you have contact with them for that first time, they're just like, one, why are you hopping out of a van? Why are you not wearing a badge and a gun? And once you get past that, it's like, hey, I'm handing out water, and this is what kind of came across the radar, and we just want to make sure you have any options. Here's things I can offer you right now. If you're not ready for it, then if you see me again, or we're driving around, flag me down, and we'll be able to help support you in that moment. And there are a few people that we've seen 2 or 3 times, and it was that 4th time that they're just like, yeah, I need something, because this isn't working for me anymore. And sometimes it's as small as just, I just need an ID, or I'm ready to at least have a conversation with you. And then it's the far end that it's like, yeah, I need a caseworker, I need to talk with a psychiatrist, because this just isn't working, and I need help. And I think it's really about relationships and communication with people. So,
Samuel, do we have any questions in the chat box we can jump to?
Not currently at this time.
Okay, so we don't have any in the chat box. So again, if you're participating virtually and you have any questions for our panelists, please feel free to write them in the chat box. So I have a question for our panelists. So you spoke about the community stakeholder engagement with different partners and agencies. Can you tell us a little bit more about that, particularly around areas of conflict or disagreement, and how you all worked through those things? Oftentimes, folks want the moon, and there may be restrictions or reasons why, as agencies, we are unable to, fulfill that 100%. So can you tell us a little bit about some of those lessons learned?
Many years ago, President Ronald Reagan said the 9 scariest words ever spoken were, "I'm from the government and I'm here to help." And I think there's that historic inherent dynamic sometimes in engaging communities that has been ever present, but necessary to work through. We've known by engaging some individuals known historically to the department, in some groups and communities, that we're going to have hard conversations. And some of that has been to own our own history as law enforcement, as public safety, and just being prepared to be as candid, I think, as possible, and as open and inviting. So I don't know that directly answers, but it's going into these conversations, relying on the community support is also going to be require thick skin sometimes, candor, and as my dad used to always say, that I've never really been super successful at following, you've got one mouth and two ears, use them proportionally. So taking the opportunity to listen and hear, to Chris's point, something as relatively simple as supplies being provided that we didn't think about with, months and months and months of planning and preparation, that came from the community saying this is what you need to be prepared for. So I think that's probably it, is being prepared for what the community has to say, being acceptive, whether it's good or bad.
Yeah, I think it's also being able to find the common ground and philosophy of what it is you want a program like this to look like, and being able to, not dig in on everything. Like, there has to be give both directions. I think we started this program specifically with the Department of Safety under a police contract, and recognized that was not something the community wanted, that they wanted this to live under the Denver Department of Public Health and Environment, that this was a public health issue. And I think it was one of those the Department of Safety had to kind of say, okay, this doesn't need to live with us. This is a good program that we don't have to take ownership for and say this is on our side. Instead, this is something that we can concede on to say, yeah, it needs to live in the department. And that was something that I think was probably difficult, but something that was willing to do. And I think that's the same with the community. It was a recognition of being able to kind of take some, that we would probably be with this program working alongside police as part of a partnership. And I think that was a difficult thing for them to have to say, yeah, that might be part of what this program is, even if we don't like it. And I think it was just finding that middle ground for everything.
Thank you. Can you tell us a little bit about perhaps testimonials, understanding the sensitivity and confidentiality around some of these situations, but for folks maybe in the community who have been on the fence or hesitant, or perhaps even some of the officers, how the success stories and how are you branding and marketing that, and advice would you have for other communities? Or is it something you're thinking about and not quite there?
Yeah, I think we're looking at how we're going to be able to market this in a positive way. I think talking about it as a start, it's a delicate thing, because I want to be able to say, here are the positives, and here's people I'd like to be able to connect to be able to voice those stories, and also recognize that I don't want to exploit our program as a positive thing at the expense of someone's crisis. That's not why I got into this field, and I think that's kind of something we're trying to overcome and figure out a best case, because we do want to be able to say, here are the positives and here's what we've been able to do. And we probably are more likely to do that through community organizations that interact with us to say, hey, this outcome actually was a really positive thing, where historically it has not been, instead of going directly to that person and saying, so I hear you were suicidal, so tell us what went better. I just think that's a really un-trauma-informed practice, and might be more, as we move forward, communities being able to see how it was more impactful to them, just what the words they're hearing.
And I think the question leads to, I'm glad you mentioned that there needs to be an intent to manage expectations. Referring to STAR specifically, I think the more that it grows, the more that we move STAR response citywide, taking police out of response, we need to make sure that the public understands when you call 911, there are certain circumstances that are going to receive a police response. If you call and say, my son has a gun and he's in the backyard threatening to kill the neighbors or threatening to kill himself, but he's also not taken his psychotropic medication for the last 2 weeks, send the STAR van. That call is going to get a police response. So helping the community understand that while we want to continue to build and evolve trauma-informed alternative responses to decrease the likelihood of negative outcomes, we have to help the public understand that certain situations will always receive a police response as a necessary component to supporting everybody's safety.
Thank you. Samuel, do we have any questions?
No, but I actually have a question. I'm just curious to know, pre and during pandemic, how has juvenile calls increased, or how has that been approached? I'm assuming with kids being out of school, being locked out, lacking that social interaction with friends, were there an increase in juvenile calls, and how are staff cross-trained to handle juvenile calls versus adult calls?
Fortunately, we've had a long and strong relationship with Denver Public Schools, recognizing that doesn't account for all juveniles within the city. It's a significant number. So one of the areas that we've looked at, and both from a data perspective as well as building increased response specific to that question, is Colorado's Safe to Tell program, where anonymously people can input information directly about a concern that they have. It could be a juvenile who is looking for resources or support for him or herself. It could be a family member, could be a neighbor. But so we have seen clearly an increased number of calls that are reported to the Denver Police Department through Safe to Tell or other avenues with our partnership with Denver Public Schools. But very simply, we have seen an increase in the calls. We've also looked at very specifically what does response to students, to schools, to juveniles look like from a behavioral health standpoint. In the city and county of Denver, there was a choice made to take school resource officers out of Denver Public Schools in response to basically community requests. Moving into this year, there will be no uniformed police officers in Denver Public Schools. So the schools now have some additional revenue that they're looking to reinvest in behavioral health response, partly within consideration is additional partnership with the Mental Health Center of Denver. But that's an ongoing conversation, recognizing that there is a larger need expressed, influenced by the pandemic, but also other factors that I think are unique to a younger population.
Can you tell us a little bit about your experience and advice for working with elected officials? So clearly by the ballot initiative, you had voter support for the increase in the sales tax, but for those of us who work in our local communities and with our local officials, what was that experience like with you, and what does that relationship continue to be like?
I feel like you're setting me up.
It's not been necessary. Any advice you're willing to give
So I
us?
can say from my side, it's been an experience for sure, because I think coming from the mental health realm, it's working with politicians and like city councils and other entities that I've never worked with. It's been kind of a how do you effectively be honest and make sure that honesty of like what a program needs and can grow is communicated the most effectively, and that letting them kind of be the ones that kind of advertise that. I think City Council with Denver has been really great about getting the message out of like, this is a program we support and want to continue to support. Same with the mayor. And being able to make sure that we're informing them in every aspect of what's going on, so that no one feels like they're left out of the loop or not sure what's going on. And also recognizing from our side that it is, there's a lot of people that want to chime in and have an opinion and take ownership and all that stuff. And I think for me, it's really important that we're recognizing always that it's about the individual that we're having contact with in the community, and it's about the program that's set up to do that, and the politics stuff can kind of be more of the higher level stuff.
And relying on, depending on people that are part of the community or representatives of the community, particularly elected officials. And a good example is, so going back to Chris's comment that STAR being community driven, of, by, and for the community, we asked our city council representatives, we have an advisory group now that's going to be an ongoing part of STAR, who will have regular meetings and input into STAR's operations. And we asked city council to identify and designate members from within their districts or their communities to represent their communities on the STAR advisory group. Some of the managing expectations, some of the some of the challenges that we know we will see, whether it be misunderstanding of data, where there may be an issue. One of the things that we saw early on was just by the nature of the crisis work, there was some data that was requested by the community that we weren't collecting to the level that they thought we should be. So we had the conversations, and then we looked at ways that we could still respond in a trauma-informed manner and do better at some of the demographic and data collection. So it's, public safety and political conversations always sometimes can be a delicate balance, but in the end, it's a necessary dance partner. We can't be effective if we don't have buy-in and support of our elected officials as representatives of our communities.
Great, yeah, and so, my takeaways from that is communication, updates, involvement from stakeholders representing those respective commission or council districts to make sure that there's voice, and reporting out, right? So making data available anonymously, obviously, for that. Do we have any other questions from audience members or our virtual audience? Can you tell us a little bit about how this has impacted the relationships, or what, any awkwardness between the social workers and the police officers in this co-response, and success stories of that? How has it perhaps influenced the culture on both sides differently?
I think it's impacted it pretty positive, only because it's one of those things. Writing with a social worker for 10 hours a day, you basically get a whole different philosophical view of how we encounter people and how we talk to people, and how we everything that police are kind of trained on. They see a social worker, I remember vividly going on a call with someone, and I was like talking with them on their front porch, and I got down on I don't want to hover over someone, I got down on my knees and stuff like that, and we got back to the car, and the officer's like, that dude could have lunged at you, and I'm like, yeah, but they're not going to lunge at me. I was trying to be supportive and helping, and I was like, it's just a different skill set, and they're just like, well, it worked, so okay. And now it's like no one even questions kind of what our clinicians are doing, because they know that we're using our clinical skills and judgment to make sure that we're connecting with that person in a very real way, to help the situation and make sure everyone gets to where they need to afterwards. Not only that, but it's amazing. I have some of the most, what we would consider more hardened police officers that didn't buy into this program in 2016 and weren't very big on the clinician, that 5 years later will call me up and they're like, okay, so I'm on this call, this person's a little experiencing auditory hallucinations, they're saying that they're suicidal at like a 6 right now, and I'm just like sitting there going, are you using my language to describe this situation? And it's amazing the verbiage that all of a sudden that they're coming in to these new situations when they don't have a clinician with them, that they're still using these things. And I think we've also seen that on STAR with the paramedics. A lot of them have actually said, hey, we never get mental health training, and just riding on this van and seeing how you guys interact actually lets us have conversations with people when we're just on an ambulance. That is much more positive than historically what we have had. So I really do think it kind of, it's that trickle-down effect of just seeing a different way of doing things that wasn't in your tool bag that now can be, and being able to have that. And I think that's been a pretty positive step in our direction.
And two other areas of unintended outcomes that we've observed. One in the realm of wellness and resilience, particularly for involving the traumas of law enforcement. To Chris's point, riding with a social worker for 10 hours a day, we've seen personal benefit to the officers themselves who have, it's not like they're assigned a therapist, but we have seen, and it's been reported out, having access to a licensed social worker that's sitting right next to you that you formed a relationship with has promoted positive wellness and resilience outcomes for officers. A second area that we don't collect hard data on this, but we never would have thought about this. Now in 5+ years of co-response, there has never been a sustained internal affairs complaint involving a police officer who responded with a social worker. There have been a couple of times where there might have been a complaint, but there's never been a sustained complaint against a cop who was serving in a co-response capacity. And I'm not saying that you can expect those outcomes, but it's one of those things when we first started looking at it, because we work closely with Internal Affairs, who is a large referral source for us to assign things through our caseworkers and our co-responders for follow-up, but that's something we never would have thought about, that also goes toward contact by contact, improving the relationship between a law enforcement agency and the community that they serve.
Samuel, we're still nothing? Okay. So any last minute advice or things you'd like to share with our audience today that work in local government and that perhaps are embarking on a new model themselves, or looking to refine things, or just thinking about how best to implement this? And not necessarily this model, but just the concept of an alternative response.
I think my biggest takeaway has always been, and it's in conversation with many communities throughout the nation, is just having that first step of saying, we don't have the solve for everything, we need help, allows a ability for growth and partnership to take place, and these programs to be able to flourish as a result of that. And being able to, I think it's so funny because our nation is not exactly the same in every single area, which is a good thing. But there is different like takeaways of like where buy-in's going to be and how buy-in is going to look and what a model is going to look like. So I think taking the idea of we want to create something and making sure that it fits your community's need of what they're looking for. It doesn't have to be a Eugene model. It doesn't have to be a Denver model. It has to make sense to your community. And being able to get all the partnerships around with that. And I think Denver is very high on supporting whatever need that is, whether it's mental health to mental health provider in a different place, or police to police a different place, or 911 to another, and being able to get everyone on the same page of like, sometimes you just need to hear from someone in your field to say, it's okay, it works, it can work, and here's some of the things we learned can be really impactful to make sure something like this can work everywhere.
And I'll conclude, I think it was a photo in an earlier slide, the best way to predict the future is to help create it. It's September 2021. You can't not do this. We have way too much input from across the world that says, from a public safety, from a municipal leadership standpoint, we have to do better. And this is one of many ways, again, not this model specifically, but the idea that we're exploring and analyzing and understanding. Sometimes, as Chris said, somebody's screaming in your face. Look past the expression to what's the need. Our communities across the country are telling us they have increased needs. We have to evolve. So collectively, we'll make the future by understanding what the needs are today.
Great, thank you so much for sharing that. So just kind of to recap some of the notes I took today from our panelists is to have strategic, proactive partnerships that best fit your community. Having a budget, or your budget and your org charts are reflective of your priorities in your organization. There are various operational models. This is just one example. So certainly research out there to figure out what is the best fit for your community. These folks are available to you as a resource. Cahoots is also a great resource. I know in my experience, having worked in the Phoenix Police Department and embarking on an alternative response model, we did a lot of research, engaged with groups like Bloomberg Philanthropies, who, not necessarily promoting them, right, but groups like them that have resources available too, where you can apply for these programs and fast tracks and hear from other groups doing similar work and other cities and partners. So just know you are not alone in this process, and there is lots of support out there as you work to figure out what best works for your specific community. Also look to consider the ballot initiatives. I think that was something that really impressed me a few years ago when I learned about Denver's model, and so obviously we as local government administrators may have limited impact on that, but certainly any advice that we can give or learn, because that can be an additional tool in which to fund some of these services if there is inadequate funding. I also took notes on ensuring that there are wraparound holistic support for those community members. So kind of who is the end user? What is our purpose with this? It's not just to not send police on calls that they don't need to be sent with. It's about that service delivery. And as public servants, that's part of our roles and why we got into this profession, is to help that individual community. And so making sure that our partners are able to provide those wraparound services. and sending the right response. So I think, you heard a lot about that today. Some calls are still going to require a police response, and so that's about setting the expectations with our community and our elected officials that, having these alternative responses does not mean there is no need for police. But as a community, you need to figure out what calls merit that response and what does not, and have the data help drive that for you. The importance of involving your community stakeholders and your organizations and making sure that they have voice and influence and influencing the model of what this will look like for you. And as part of that data, looking at your high call volumes, the times, the days that those are being received, as well as the location, if you're looking to pilot something, and then look to expand that. And then reframing our response to our communities and making sure that we have follow-up to those folks that are being served. So, continuing to work with those agencies, that it's not just a one-time contact and we're done, but making sure that they have those continued supportive services and check-ins as needed. Okay, so if there's nothing else, we'll give you a little bit of a gift of time to take a bit of a break, and please give a great round of applause to our two panelists here. We greatly appreciate you.
Thank you.